It's been a long day. You have a patient who is actively dying after a sudden CVA. The family has been camped out all day at your workstation.
Code blue, room 142, bed 1. Code blue, room 142, bed 1.
The patient is unresponsive and the CNA is performing CPR.
Do not resuscitate. He has a DNR.
I have the power of attorney. He has a living will that states all heroic measures must be taken.
Escort the family out while calming them down. You need to concentrate on the patient. You have something in your pocket. Click to see what it is. Keeping these cards in your pocket can be critical, as in this instance, it helped to confirm that the patient was indeed a DNR upon admission to the floor.
Stop CPR immediately.
The CNA has stopped CPR. You need to check the patient's vital signs. The patient ends up having no palpable pulses and there are no signs of life. The nurse tells the Code Blue team that the patient is a DNR status and they should leave.
Get back in there. You need to resuscitate him.
The son is upset, but the patient had a DNR upon admittance. As we continue, think about the following questions. Did the nurse have a crucial role to play in this situation? If so, what was it? What responsibility, if any, does the family have in a situation like this? What responsibility, if any, did the patient have in this situation?
Please tell me the sequence of events.
The patient remained on bed rest after his IVC filter placement surgery that concluded at 16:30. He had been stable. He requested to get up and go to the bathroom at 18:15, and I provided the okay for him to walk to the restroom with the assistance of the CNA after one last incision assessment. The CNA reports that while getting him out of bed, it was discovered that the oxygen tubing was too short. She left to get longer tubing for the patient's oxygen, leaving the patient under the supervision of his daughter. When the CNA got back, he found the patient had taken the oxygen off and left it on the bed as he tried to get up on his own, despite the pleading of his daughter not to. She witnessed the collapse and yelled for help as the CNA was returning to the room. The CNA, unaware of the DNR status, began CPR and called a Code Blue.
The doctor is satisfied with the report. He asks to speak to the family.
Can you all please come with me so we can talk?
I am going to sue this hospital.
You overhear the outburst. Your intuition tells you are going to court. Advance directives is a term used to encompass documents such as a living will, durable power of attorney, and durable power of attorney in healthcare, DPAHC. A living will is simply a statement that the patient makes in writing describing his or her wishes pertaining to how or where he or she wishes to die, and it becomes active when a person has been deemed incapacitated, vegetative state, or terminally ill. A durable power of attorney is a legal document that allows a trusted individual, friend or family member, to be the legal representative in all non-healthcare legal matters involving a patient, like an elderly person. A durable power of attorney for healthcare, DPAHC, is a document through which a patient makes known his or her wishes about the treatments he or she wishes to have or not to have throughout the course of an acute illness or in the dying process. Had the son in this particular case kept an ongoing and open discussion with his father about any changes he wanted to make to the DPAHC prior to the emergent hospitalization, the son may or may not have had more decision-making capacity. Unfortunately, that wasn't the case, and thus there was an unfortunate disconnect between the two key parties involved in the DPAHC, the appointed decision-maker and the patient. This is not an unusual occurrence. A recent study expands on this by stating, when discussions about end-of-life preferences do take place, they frequently lack the clarity and detail needed by significant others and healthcare providers to honor their preferences. Clinical scenarios like this are tenuous at best, and more so if a family is in disagreement with each other or their loved one at the time of an arrest or when actively dying. One has to wonder if the horror the family experienced as they witnessed their father's life come to an abrupt end while healthcare providers withheld care was an influence in their decision to file a lawsuit. There are a lot of nuances to what we do that are not well understood by laypersons. 3 pieces of information concerns me in this case. The lack of communication between the father and son with regard to updating the patient's preferences. The misunderstanding the son had that a power of attorney can override the wishes of a patient, and the lack of communication between both patient and family. Perhaps the son could have double-checked the code status with the physicians and verified that the advanced directives were in the chart or updated with the patient prior to surgery. Maybe a conversation between father and son prior to surgery could have closed the circle of communication. The fact is this, that there are no better advocates for healthcare consumers than themselves, the patients, family members, or trusted friends who hold the durable power of attorney for healthcare, DPAHC. That said, we should always ask ourselves, does a family member or one who holds the power of attorney know what effective advocacy means? Part of advocacy is knowing what questions to ask, what information to provide and verify in the hospital, and always knowing at any given moment the exact wishes of a loved one so there are no surprises or unnecessary and unhealthy turmoil surrounding a patient and family during a health crisis. Advanced care planning would have played a critical role here, and this case illustrates why. With every hospitalization or change in health status, there should be a family talk taking place so that everyone is in line with what the patient wants treatment-wise under various circumstances or stages of illness, i.e. CHF. While nurses seem to approve of and support discussion related to end-of-life preferences and advanced care planning, they lack sufficient knowledge to feel comfortable initiating or engaging in crucial conversations. Studies have found that nurses identify the benefits of advanced directives and have positive attitudes, but lack knowledge and confidence to effectively discuss end-of-life issues with patients and families. The literature related to nurses' attitudes about advanced directives points to an unmet need for increased knowledge and confidence to address barriers and ethical dilemmas in end-of-life care. Putman-Kasdorf, 2009. It is our responsibility as nurses to teach patients and their family members one very important thing. With every hospitalization or change in health status, advanced disease, the talk has to happen. Questions must be asked. Advanced care planning doesn't stop once an advanced directive is signed. The concept is a living thing. The patient's voice must remain front and center during each discussion and healthy death. It would serve our families well and prevent costly lawsuits if we started the conversation and engaged in thorough teaching about advanced care planning.